Our next speaker probably does not require any introduction. Dr. Beth Beadle is a radiation oncologist and the director of head and neck radiation oncology at Stanford. As you heard in just a few minutes ago, she is a consummate professional who marries her clinical expertise with compassion and care. Beth, thank you again for joining us today and to speak on the topic of how to monitor for worrisome signs after head and neck cancer treatment.
Thanks, Heather, and thanks to the organizers for inviting me. As Heather mentioned, my name is Beth Beadle, and I am a head and neck radiation oncologist, and there's absolutely no pressure after the last few moments. I want to thank all of you for joining us today. Now, I really want to talk about kind of some general themes about recurrence and how to monitor for it in the next session, looking at types of recurrence, how your cancers can come back, what the patterns and rates of recurrence are, and recommendations for monitoring. And then putting things into your power. What are common symptoms you can look for? What are the options for additional testing? How can we balance the risks of additional testing? And most importantly, how can we manage the stress and anxiety? I think that going through life, most of us don't think every day that perhaps tomorrow we'll be diagnosed with cancer. But once we're diagnosed with cancer, it's hard to go through a day without wondering whether or not it would come back. And that's what we want to manage to make sure that we allow and empower people to live good, whole, wonderful, fulfilling lives without that overwhelming concern and anxiety. Now, as I think you've heard today and through our previous annual symposia, head and neck cancer is really an array of diseases. And one of the things that we have to think about with recurrence are, in fact, that the patterns of recurrence, the types of recurrence, and the likelihood of recurrence varies a lot based on this. So most cancers in the United States develop in the head and neck are squamous cell carcinomas. But by far and away, that's not all of them. And different cancer types in different areas dictate the type of treatment you will have and the likelihood of recurrence and where those cancers are likely to recur. So you may have met people today, you may have met people during the course of your treatment or in the waiting rooms and follow-up where you have said, oh, I have tongue cancer. And they say, well, I have tongue cancer. And you say, oh, well, I'm getting radiation and chemo. And they say, oh, I had surgery. And those are nuances of the types of cancer that are really important and will dictate how we monitor for those cancers and what the likelihood of recurrence is, so that we have given the right treatment at the right time, but also monitor appropriately throughout that follow-up period. Now, when we talk about recurrence, we talk about cancer coming back. And cancer can come back in a variety of ways. What we call local recurrence is that cancer can return in the area where it began. So if you have a tongue cancer, you can have it treated with a combination of surgery, radiation, and chemotherapy, or any or all of those. And in fact, the cancer could come back where it started. I think this is especially challenging for patients who had surgery who say, well, but you took it out. And the thing is that whenever we take something out, we have to leave something in, which is the rest of you. So there's always a margin and an interface between what we took out and what we left in. And that interface is a place that cancer could come back. I have patients who have tonsil cancer who said, well, I can't have tonsil cancer. I had my tonsils out as a kid. But again, they took out some of that tissue, but not all of it. And that remaining interface is at risk for a cancer. What is regional recurrence? So a lot of patients who have head and neck cancers, it develops in the throat, the tongue, the voice box, but then it goes to the lymph nodes of the neck. The lymph nodes are considered a regional spread area, and you can have a recurrence in the neck, which is typically the regional basins of drainage. So it's sort of like a sewer system, and those cancer cells can get in that sewer system and they can go and collect in the lymph nodes of the neck. And that can happen if you had neck lymph nodes positive at the time of initial diagnosis, and that could happen later on. And then finally, we have distant recurrence, or what's typically known as distant metastasis. And this is where the cancer can get into the bloodstream, and it can go anywhere else in the body and set up shop and form a new tumor. So for patients who say, oh, well, I now have a lung cancer, I had a head and neck cancer and a lung cancer, oftentimes that's a head and neck cancer that metastasized to the lung. This is not exceptionally common for most patients with head and neck cancer, but it is possible, again, depending on the type and location. And most likely those areas would be the lungs, the bones, or the liver. And unfortunately, some cancers recur even with the best possible therapies. And that means that since cells are so small, and for those of you taking notes, the tip of your pen is a cubic millimeter, and that's 1 million cancer cells. A surgeon can't take all of those out. I can't detect them on a scan. We can't monitor them with a PET scan or a CT or anything like that. So right now we have to do our best to treat based on what we see and the patterns of spread that we know, but then we have to monitor really closely to make certain that one of those cells either didn't live through treatment or hadn't learned to spread before that. And this is different than the treatment of benign diseases. So if any of you have had an appendectomy or a cholecystectomy, removal of the appendix or the gallbladder, you go in typically after your surgery for one visit, they make sure you're healed, and they send you on your way. They don't need to bring you back in and check every 6 months to see if your appendix grew back or your gallbladder grew back, because it wasn't growing back. But for cancer, it's a living and breathing thing, and at any time, even with the best treatment, one of those cells could have learned to live through what we threw at it and what your rest of your body endured and become a recurrence. And we have to monitor for that and understand that risk. So again, the rates and patterns of recurrence are very dependent on the types of cancer. As I mentioned, most head and neck cancers are squamous carcinomas. And for these cancers, the most likely area of recurrence is local or regional, so above the collarbone, either where it started or in the neck, and most likely in the first 2 years. So the thought on that is, if we give appropriate treatment and it was limited to the head and neck, and then we stop that treatment, if anything lived through it, within the first 2 years, it's had a chance to grow and become a problem. And if it hasn't, it's unlikely that it ever will. And the way we as physicians look at that is in this graph down here, where this is the percentage of patients who've had a failure in the primary site or in the neck as we go into the future in many years after the end of treatment. And this is 2 different treatment approaches, and you can see that as this line goes up, that each time there's a little tick mark up, that's a patient who's unfortunately had a recurrence. And you can see there are different rates between these 2 different treatments. But once we hit 2 years, after going from 0 to about 8 or 12%, they're pretty flat. So again, most patients who are going to have a recurrence are going to have it within the first 2 years. Doesn't mean it's impossible to have a cancer come back after that, but it's much less likely. And for those patients with HPV-associated cancers, which are now typically the most common head and neck cancer in the United States, these rates are very low overall, less than 10%. But many of you have cancers that are not the squamous cell carcinomas or the HPV-related carcinomas. And in that case, these generalities don't necessarily apply. Some of them some types of cancer have increased risks of distant disease. So increased risks of going to the lungs or the bones. And some have longer time courses where we're less likely to be relieved when we hit the 2-year mark because they are more likely to kind of wait for later. They're very slow growing and you can see recurrences much later. So your treatment and your follow-up both have to be individualized for you. Now, we do get to look for national guidance on how to monitor. And we actually have several representatives from Stanford on the National Comprehensive Cancer Network in head and neck cancer. And so they're a group that get together with surgeons, medical oncologists, radiation oncologists, among others, and say, how should we treat patients based on best data and how should we follow them? And unfortunately, we don't have great data on follow-up because, again, things vary so greatly. So they end up sort of making recommendations based on conference and based on compromise, which sometimes just involves everyone being angry. But the best thing we have is sort of this to hang our hats on. So knowing that the most likely time for recurrence for most head and neck cancers is within the first 2 years, that's when they want to intensify people coming in and being evaluated. So they recommend a history and physical exam, which is the complete physical head and neck exam, as well as an endoscopic exam of the throat, if applicable, every 1 to 3 months for the first year, every 2 to 6 months for the second year, every 4 to 8 months for years 3 through 5, and once a year after that. So some people say, oh, but I'm done with my radiation, I don't need to see you again. But in fact, I want to see you, one, to make sure that your cancer has gone away and stays away, and the other is to talk about all of the side effects that I have caused as a radiation oncologist, how to minimize those in the short term, and most importantly, the long term overall. They also talk about the role for imaging, labs if needed, if we evaluate or treat the thyroid, monitoring the thyroid, dental evaluation, especially for patients who got radiation, can affect the teeth in the long term. And again, most importantly, supportive care and rehabilitation. So really making certain that we stay on top of the things that can come back in the long term in terms of side effects to keep you healthy. Because again, our number one priority is to take care of your cancer, but we also want to keep you speaking, keep you swallowing, have your neck be nice and supple and mobile, your teeth in good shape, and all of those things. So really, one of the things that is most challenging about this guideline is that they are really wishy-washy on imaging. And I know that I see a lot of patients who say, well, when can I have my next PET scan? When can I have my next MRI? Because there's definitely a degree of assurance in a scan that looks internally to make certain nothing's there. But in fact, their data on this is somewhat lacking, and ultimately their statements on this nationally are, there are no consensus guidelines on the frequency and modality of routine post-treatment imaging in an asymptomatic patient, and there are no data to support substantial benefit for routine imaging in an asymptomatic patient with negative examination. So that's one of the reasons that we don't necessarily do imaging every few months, because none of the data supports that it actually benefits you as a patient. So from a practical standpoint, we really have to sort of stand on a three-legged stool in order to monitor your cancer appropriately. First, we have to focus on the most likely location of a recurrence. That again depends on the type of cancer that you had and where it was, and in the most likely time frame of recurrence. So if you have a tonsil cancer that's HPV related, your risk of it coming back is low, but not zero, and the most likely place would be in the head or the neck area, and the most likely time frame would be in the first 2 years. So that drives us to what we're going to look for in terms of what we do on physical examination and what we ask you when we see you. So really thinking about it, there are 3 pillars of detection and post-treatment monitoring: your symptoms, imaging, and clinical examination. So let's talk about those. Now, symptoms I'll get to in a little more detail in a moment, but really the short version is to notify any of your physician team if you notice something new. As you finish your treatment, you're going to get to a new normal, and our hope is that over time, over months to years, that's going to continue to get better. But if you have a consistent setback, if you have for 2 weeks new pain, new difficulty swallowing, new swelling, something that is different, then we want to know about it, because you know your body best. And if you've been on a certain trajectory and that trajectory goes in the other direction, then that's something that really will lead us to do a further investigation to see what the cause of that is. Also, clinical examination. So that's why we suck you back into clinic every few months, because fundamentally, I can see and feel most cancers in the head and neck. And so routine evaluations with the physicians who treated you, if possible, are best, because I know what it looked like before, I know how it responded, and I know what we can do for that. And by I mean your doctors, not necessarily me. So feeling the tumor and looking at it are really the key for diagnosis of local and regional recurrence. So this is a patient of mine. This is one of the scope procedures for those that have had them, where we look through your nose and then down your throat. So this is at about this level. This is the patient prior to treatment. This is the epiglottis here. This is the base of tongue. That's the back of the throat. And this is an asymmetry that should not be there, that in fact is a cancer. we put this patient through chemoradiation, and at the end of treatment, you can see everything is more swollen. The epiglottis is nice and poofy now because it's angry with me from the radiation. It is taking it out on you. This will get better, but we no longer have that mass there. So this has all gone away through the course of therapy, as we would hope and as we would expect. But 6 months later, the patient came in, and now we have the lesion is back. I can see that. It wouldn't necessarily be apparent on a scan because when you're not looking with the scope, all of those tissues will fold in on each other. So it's unclear whether this would have been picked up on a scope or on a scan. But when I look at it, I can see it. I can feel nodularity. I can see new redness. So physical examination and ongoing evaluation with your physicians is really important. Now, what is the role of imaging? CT scans, MRIs, and PET scans. They're really important at the end of treatment to have a new time point for where you are post-treatment. So looking back at this patient had a tumor prior to treatment that should have been visible on scan. After treatment, all of those tissues would look different because of the effects of the radiation and the chemotherapy, but the tumor would be gone. And now we can see if it comes back. So getting imaging post-treatment is really important. We typically wait about 3 months so that a lot of that swelling can resolve, but it's really important to have a new baseline of what the tumor looked like after the therapy. But it's unclear what we should do after that. Really, again, most studies suggest that we should only image with new symptoms, abnormal findings, or risk that I can't assess by looking or feeling. So if you had a cancer that was tracking along nerves towards the brain, I can't feel that, so that's a good reason to get an image. But if I could see or feel your cancer beforehand and it went away during treatment, unless you have new symptoms, there's not a lot of indication to have additional scans. And in fact, my prior institution did a lot of scans, and they actually looked back and said, if you look at 1,500 patients who had head and neck cancer that were treated with radiation and got routine imaging every 3 to 6 months after their course when they had no symptoms, only 12% ever had a recurrence, and between 60 and 80% of those either had a reported finding that they called their doctor and said this is new, or when they came in for a clinical examination, something was found. So the majority of those scans showed nothing. 70% of those recurrences, like we mentioned, was in the first 2 years. And if you say, well, but the scan might get it detected sooner, the short answer is that it didn't, and it also didn't have any effect on survival. So then we had to pivot to additional therapy for a recurrence, and there was no difference in those outcomes and how successful treatment was for patients who had imaging versus who were found on clinical examination. And clinical examination is both what I do and, most importantly, what you feel. But why not scan everybody all the time, even just for reassurance? Because if you're asymptomatic, the chances of having a false positive are high. And every time we do a test, they're going to look to see if they can find a thing, because they don't want to miss anything. And if they find things that are unrelated, then given a cancer history, we have to go and evaluate them, which means sticking needles in things, doing more scans, and possibly putting you at risk for side effects of all of those other things. And so it's not an insignificant risk. If it's more likely you're going to find something unrelated than you're going to find something related. So the other thing is that if we do a couple scans, that's one thing. But if you're 50 years old and have a treated head and neck cancer, getting a scan every 3 months for the next 40 years is a lot of scans. So it's a lot of scans for you and for your body. And so while, again, we want to scan appropriately, we don't want to scan too much. This is a patient that I saw last week who actually had a fairly sizable tonsil cancer with lymph nodes. We treated him with radiation and chemotherapy. He did well during treatment. 3 months later, he had no evidence of disease on examination that we could see. Everything looked like it went away, but we did that post-treatment single image to just make certain everything was gone. Everything in the head and neck was gone, but this is a picture of his chest, and the way the PET scans are are looking, it's as if his feet are coming out towards you and his head is behind the screen. So this is his right side and his left side. These are his lungs. That is the top of his heart. That's his breastbone. These are his ribs. And on this side, you see normal ribs. And on this side, you see a mass. And this is read by the radiologist as concerning soft tissue mass in the ribs and cannot rule out recurrent cancer. So I go in to have this conversation with this patient, and he said, oh, well, that's where I had an old football injury, because that's going to look the same way. And so again, if we go and pull old scans, we can see it was there before. But every time we do a scan, there's a chance that we're going to see something that is normal. We don't scan Heather every 3 months. We would find something if we did scan Heather every 3 months. And so we in no way think that ignorance is bliss, but we also have to do the right test at the right time and not put you through additional therapies and additional evaluations that could actually be worse for you. The other thing is that it's really well known that follow-up visits and especially scans cause stress. And they actually have termed it in the literature scan anxiety, because when patients have scans, it's hard to think about perhaps this would be the one that tells you some bad news. So this is actually a survey that was done for over 200 patients of all kinds of cancer, not just head and neck. And you can see the percentage of participants here who said that they rated at least a 4 out of 10 in severity related to their last scan in anxiety, feeling worried. Over 30%, trouble sleeping, a feeling of dread, poor concentration. So all of these things, again, are really important. And while we want to do it when we need to, it's also a lot to put patients through if we think the yield is going to be low. And there was a letter to the editor regarding this article where I felt the patient perspective, of course, was the most powerful, where one patient said, in the weeks running up to the scan, I began to question every single ache and pain and worry that it might mean something. As well as this, the ludicrous number of irrational and often paranoid concerns begin to take over my head. So the pre-scan nerves are pretty terrifying, but as scan day approaches, the real fears kick in. And that's a lot. And another patient said, while we wait for results, I almost lose the ability to speak. Apparently, I go a bit gray as those terribly terrifying but very possible scenarios go through my head. And strangely, when I do get good results, the feeling of relief is remarkably short-lived. I think it must be too complicated to be able to rejoice in being told that this time it's okay. This time you got away with it. And I think it's really hard to interpret whether or not you just kind of dodged another bullet and whether another one's coming. And what we want to do is make certain that we give appropriate evaluation and care when things determine it. But I want you to all live like you're cancer-free as you move forward. So what's the best test for recurrence? I really think it's the patient. So again, you know your body best. And you know how things have been with the quote-unquote new normal after cancer therapy. And overall, you can have good days and bad days, but most of the time things get better week over week, month over month. But symptoms of recurrence that should be alarming depend again on the location of the primary tumor, but they include new throat pain, new sores in your mouth or your throat, the new feeling of swelling, new difficulty breathing, new congestion, or new masses or swelling in the neck or under the chin. But things to think about are this. Can you go back to when that happened and correlate it with something that may have happened? So fire season around here is often very, very concerning because all of us end up having new irritation, new nosebleeds, new dryness, new throat irritation, new pain, and that's because it's fire season. And so trying to seek, is there a logical explanation? Oh, my tongue hurts more. Might have been that Mexican food that I had, or a special night with some alcohol or something like that. So that's not to explain away your concerns, but see if in your own mind if there is a correlation. Most importantly, how long has it been present and has it happened before? All of us, regardless of our cancer history, can have a cold, a flu, anything like that, but typically that gets better, goes away in a few days. If any of these symptoms persist for 5 to 7 days, then your team wants to know about it because we'd rather be safe than sorry, make certain that we are not dealing with a recurrence and in fact have an explanation for it. Because these aren't all recurrences, and that's a good thing. So you can get sick like everyone else. You can have mouth sores or discomfort related to irritation in the mouth. You can have increased congestion due to environmental allergies or fire, smoke. And really, one thing that we often see after treatment is you can have new neck swelling, which often is very concerning for patients, which is in fact lymphedema, which is fluid accumulation, oftentimes under the chin or in the top of the neck. This typically is worse in the morning, gets better during the day as you're upright, and it often can be significant and firm, but it definitely has these patterns, and if it's worrisome to you, then we want to know about it. So any changes, because you're the best evaluator of recurrence there. So your treatment team should know. Now there is the possibility to develop blood tests, and these are ongoing to try to monitor for different types of cancer. Some of you may have friends or family that have prostate cancer or monitored for prostate cancer, and they do PSA blood tests, and there's an interest in getting an HPV-related test or an EBV-related test for nasopharynx cancer, blood tests for cancer. But right now these are really experimental, and they're hard to know as physicians how to process. So they can be positive without disease, they can be negative with disease. And I must say that these right now off of a protocol are really dangerous because we don't know how to manage them. And just sharing a personal anecdote, for those of you that know me, I have a terrible family history of cancer and I'm considered high risk for everything. And right after my mom passed of pancreatic cancer, I wasn't feeling well. And so a physician ordered labs for me to check out why I was tired and having headaches. And they ordered a bunch of blood tests, not really going into detail with me, that proved I was a little anemic, a little hypothyroid. And they sent a tumor marker for ovarian cancer without telling me that was 3 times normal, which then prompted an entire evaluation about whether or not I had ovarian cancer. So scan, ultrasound, and telling my father, who just lost his wife, that I was being evaluated for this. So they found nothing. So what did they decide to do? Well, let's test it again. So 3 months later, they tested it again, and it went up. So we got to do all those tests again, all of which were still negative. So what did we do? We did it 3 months later. So a year later in this, the lab number went from 3 times normal to 10 times normal. All of the scans were negative, and they proposed to do exploratory surgery, opening me up and down, to see if they could figure out what was going on, which I declined. So again, having a blood test that you don't know how to process doesn't make you feel better and doesn't necessarily lead you in the right direction. But what it can lead to is a lot of extra tests without a real benefit to you. So this is ongoing, and we hope to find a place for it, but right now it's experimental. So overall, I hope I've shown you that the risk, location, and timeline of recurrence is very personalized based on the detail of your cancer diagnosis. And the post-treatment monitoring really should be customized for you. But for most patients with head and neck cancer, the recurrence rates are fairly low. Most occur within 2 years. And the best indicator of recurrence are your symptoms that you escalate to us because you're the experts in your disease. So really, when we think about it, our 3-legged stool is pretty wonky and not a great place to sit because the legs are not in any way equal. The most important thing is your symptoms. Secondary is clinical examination, and I would argue that for most cancers, imaging is a distant third until we have reasons from the other 2 to evaluate more fully. One last thing before I close, I just want to say that for not all, but a lot of head and neck cancers in the United States are related to the human papillomavirus. There is a vaccine for this, and it is well established. It is recommended initially for children, initially for girls. It was expanded to boys. It's now, in fact, approved for up to age 45. So this is a great way to make certain that less people have to undergo chemotherapy, radiation, and surgery for these type of cancers in the future. And we are improving, but by no means successful at the HPV vaccine. The latest data is children got 1 dose or more were 75%, and we're actually up to date with recommendations are 58%. So I'd encourage each of you to talk to your families, friends, church groups, all of those things to encourage children and people up to 45 to get vaccinated, because that's how we're really going to prevent the risk of recurrence, is preventing the disease itself. So just thank you again to everyone in the Stanford Head and Neck group. My partners, you met Dr. Gensheimer this morning and Dr. Kalibas in medical oncology this morning. All of our surgeons, our amazing speech pathology team, including Teresa, who is new, who I failed to add to this slide. Our nutritionists, all of our radiation therapy team. For anyone who knows me knows Allison Jensen. She's really the greatest gift to my Stanford career here. She is my nurse coordinator, and anything positive about me is due, honestly, to Allison. And then most importantly, I want to thank all of our patients and our families. You led us in at an extremely challenging time, and we're grateful to be part of your journeys. So thank you.